Wanted to welcome you to our echo session. It'll be today from 12 to 1, and Emily Ridley is presenting. We will be doing some introductions. We'll have Emily do our presentation. We'll have some questions and discussions and then go through our next sessions. For our participants, if you could please share in the chat room your name, your employer, your position and credentials. And if you could also please put your email in, that way we can get credit issued for attending. And we'll go ahead and start with introductions from our subject matter experts. Let's go ahead and start with Dr. DePetty.
Well, is it good afternoon? Probably by a couple of minutes somewhere, except for obviously I know Dr. Bretler's going to follow me, and he's on the West Coast. Thank you for having me. My name is Don DePetty. I'm here at the University of South Carolina University and School of Medicine. I'm the Health Sciences Distinguished Professor. I've had a long career in primary care medicine. I'm an internist, but also did some specialty training in hypertension and vascular disease. And I'm thrilled to be here today, and I'm looking forward to the presentation.
Thank you, Dr. DePetty. We'll go ahead and go with Dr. Bretler.
Hey, good morning and good afternoon, everyone. Jeff Bretler, internist by training, and from Los Angeles. I help oversee the hypertension program in Kaiser Permanente in Southern California, faculty with School of Medicine here, and also consultant for the Pan American Health Organization. Happy to be here. Looking forward to the talk.
Thank you, Dr. Bretler. Emily Ridley is one of our subject matter experts, but I'm going to go ahead and introduce her in just our next slide. So she is our presenter. She is a PharmD. She's a clinical pharmacist with Prisma Health in Columbia, South Carolina, where she's worked for 25 years. She's a clinical instructor of internal medicine for the University of South Carolina, School of Medicine, Department of Internal Medicine, and an adjunct assistant professor for the University of South Carolina College of Pharmacy. She works within the Prisma Health Midlands Internal Medicine Center, an internal medicine teaching clinic serving primarily a low-income, urban, and rural population of patients. She assists in the management of patient medication therapy, focusing primarily on primary prevention of cardiovascular disease, hypertension, diabetes, anticoagulation, and medication access and adherence. She's heavily involved in teaching internal medicine residents, pharmacy residents, medical students, and pharmacy students. She currently is serving as the consultant to the Pan American Health Organization, PAHO, with the Hearts in the Americas program. Welcome, Emily Ridley.
Thank you very much, Kathleen, and good morning and afternoon. Good afternoon to everyone online. I'm so glad to see all of you, and thank you for joining us today. I must say that it was providential that we should have the topic of the role of the pharmacist in hypertension management and team-based care today, as this week is actually National Pharmacy Week. If we have any pharmacists online, happy Pharmacy Week to you. And for those of you who work with pharmacists, please make sure you wish them well this week too. Well, the topic today was chosen for this iEcho series because another arm of the Constellation Quality Health CDC grant includes an in-office pharmacy pilot in rural physician offices. So this topic is very timely and applicable. Next slide, please. Here are the objectives that we'll be addressing today. Today, we'll be discussing team-based care. We will provide evidence for how the pharmacist can significantly impact hypertension management. And finally, we will be discussing the role of the pharmacist in hypertension management and cardiovascular disease risk reduction. Next slide, please. I've included some abbreviations that you may see on the slides as we go through. Next slide, please. So starting with team-based care, the American College of Physicians has a great toolkit online to help a team develop. This definition here comes straight from ACP, and I think it's actually a very helpful one. Team-based care strives to meet patient needs and preferences by actively engaging patients as full participants in their care, while encouraging and supporting all healthcare professionals to function the full extent of their education, certification, and licensure. You notice that there's particular focus on the patient and the healthcare professionals involved. The patient, of course, is part of this team. When we talk about hypertension management and team-based care, there are several specific areas of focus, although there are many others we could probably list. The specific areas of focus are medication management, supporting adherence to medication therapy, home blood pressure measurement by the patient, and patient follow-up. Different members of the team may focus on different aspects listed. Next slide, please. We all know that hypertension control has many barriers. Here are just a few which have been categorized into provider barriers, community barriers, system barriers, and patient barriers. With provider barriers, we think about clinical inertia, not starting or up titrating medications, adhering to treatment guidelines versus using own clinical judgment, not being certain that the blood pressure readings seen in the office truly represent the patient's home readings, that fear of white coat hypertension, and the lack of reimbursement for spending extra time with health coaching. Within community, there are several barriers as well. Having access to healthy foods is a challenge that I see on a daily basis. The zip code in which our office is located is considered a food desert with only one grocery store available. Often we see patients use gas stations and places like dollar-type stores to purchase their groceries, and the options are very limited with little to no fresh vegetables and fruits. Having someplace safe to exercise is a barrier. I have patients who say it's really not safe to walk in their neighborhoods, or the park near their home is not a good place to go certain times of the day. Without that access, options for exercise may be greatly limited. Not having adequate social support through family, friends, and neighbors, and not trusting the provider. Sadly, we are all aware of some of the terrible things that have occurred in the past at the hands of providers. So patients, especially sometimes some of our older patients, may have some inherent provider mistrust. Challenges with transportation can be very problematic. It could involve getting to a grocery store or the pharmacy, and certainly getting to provider appointments, especially with patients in more rural areas. System barriers can include challenges in accessing quality care, being able to obtain a follow-up appointment in a timely manner, and truly having continuity of care can be limited based upon provider availability. Costs of medications definitely are a huge issue. And having no health insurance or health insurance that does not cover enough is a problem. The lack of truly standardized blood pressure measurements is also an issue. Patient barriers consist of medication side effects or even fears of potential medication side effects because of something someone else has told them. Adherence with medication, which can be for many reasons, memory, finance, simply just not wanting to take medications, period. Financial barriers such as cost of medication or the cost of healthy food. Truly understanding hypertension and why lifestyle changes and medications are needed and how to implement them. And last and not least are competing demands. Sometimes a patient's concern for their own health, for what they see as a silent disease, is not high on their priority list when they have other priorities or challenges occurring with family, job, and transportation. Next slide, please. So to address these barriers, team-based care is needed. This slide shows the who are members of the team. Of course, the prescriber is listed at the top as they generally are leading the team. The team also may consist of a pharmacist, a nurse, community health worker, social worker, and others who are not listed, like dietitians, counselors, and more. And of course, at the very heart of team-based care is the patient and/or their caregiver. Next slide, please. So what are the roles of the various team members within team-based care of hypertension? I have the team members from the previous slide listed here, with the exception of the patient or caregiver. Team-based care can look different across settings. As you can see on this chart, there are multiple people who could fit within certain roles. You may have teams who assign specific roles or tasks and always follow that same course. You may also have teams where different people play a different role depending on what the patient needs are and what needs to be addressed. Next slide, please. What do guidelines say about team-based care? You may or may not be familiar with the 2021 WHO World Guidelines for Hypertension. These guidelines have a number of different recommendations. However, they specifically address team-based care and how it can improve hypertension control. They suggest that the medication treatment for hypertension can be provided by non-physician healthcare professionals, such as pharmacists and nurses, provided certain conditions are met. Next slide, please. We have these guidelines, which are based upon solid clinical data. So let's look specifically at some of the data and information we have about improving hypertension control through team-based care. Next slide, please. Of course, we have to start with Kaiser Permanente. And I must recognize Dr. Jeff Brettler, one of our subject matter experts who's with us today, as he's part of Kaiser Permanente and has been a key part of the data that I'll be sharing, actually from multiple studies and publications mentioned. Kaiser Permanente has truly been a leader in improving hypertension control. Kaiser decided to reach the million hearts goal, a 70% hypertension control across their system. And they actually went above and beyond this goal and improved blood pressure control from 54% to 86% overall from 2004 to 2012. This was across a multi-ethnic population and was accomplished through a series of changes in healthcare delivery. Some of the changes made are listed, including helping the staff to work at the full scope of practice, implementing an electronic health record, confirming initial blood pressure elevations using a quality performance tool, and two of the big ones are actually starting the hypertension team-based care and implementing a hypertension protocol. Next slide, please. This graphic shows us the hypertension control rates across all demographics after implementing the change. Across all ages, races, and sexes, the hypertension control rate exceeded 80%. You can see the breakdown by races in the pie chart on the right. They truly did an excellent job in improving the control and have continued evaluating how to improve control further since then. Next slide, please. Another outstanding example of efforts that have led to increased hypertension control are the efforts of the Pan American Health Organization through Hearts in the Americas, which is part of the worldwide WHO Global Hearts Initiative. As you can see, Hearts in the Americas focuses on preventing and controlling cardiovascular disease through primary health care within the countries. This initiative, which began just 8 years ago, has now been implemented and expanded in 33 countries. Next slide, please. After the implementation of Hearts in the Americas in 12 countries, an innovation group was appointed, which included a multidisciplinary group of experts who had in-depth knowledge in the field from the first 12 implementing countries, in order to review the recommendations of the major hypertension guidelines. Their focus was how to implement the guidelines, and they also reviewed hypertension programs in high-performance health systems like Kaiser to really understand what these health systems did and how they implemented a change so that it worked well. The group wanted to ensure sustainability of the Hearts in the Americas initiative. This group developed 5 main domains of care delivery: diagnosis, treatment, continuity of care and follow-up, delivery system, and system for performance evaluation. They then selected 8 critical and independent interventions that led to significant and sustained improvements in hypertension control in these large health systems. You can see the 8 drivers outlined in the table. These drivers resulted in 17 implementable actions. They also developed scorecards to help translate these drivers into process indicators. As you can see, team-based care and task shifting is an important driver here, along with standard treatment protocol. Next slide, please. Looking specifically at the team-based care and task shifting driver, they identified that only using physicians for care delivery contributes to problems with timely access, lack of efficiency, inequity, and costs. A key problem is the shortage in most of the low and middle income countries of physicians to treat hypertension. However, using the team-based approach would offer the opportunity to provide adequate treatment and follow up patients in a timely manner. They specifically cited the HOPE-4 study, which used non-physician healthcare workers to address hypertension, thereby improving blood pressure control significantly compared to a traditional physician-centered strategy. They developed 3 recommendations involving the use of non-physician health workers who are trained and certified to measure blood pressure, follow up blood pressure, and titrate medications under supervision and with use of a protocol. This article truly is an excellent reference and guide for targeting specific areas in improving hypertension control within a system or a clinic. And you'll notice Dr. Brettler's name down there at the bottom. Next slide, please. We cannot talk about team-based care without talking about a standardized treatment protocol for hypertension. Standard hypertension protocol has been mentioned multiple times already: Kaiser, Hearts, the drivers. Having a standardized protocol for treatment with medications as well as follow-up plans is absolutely essential in moving forward and optimizing control. A protocol addresses the issue of clinical or therapeutic inertia. It ensures consistency across management and is guideline-based. It has been proven to lower blood pressure equally across a diverse demographic of patients, when drugs from complementary classes are used together. And of course, it allows expanding management beyond the prescriber alone. Next slide, please. We have reviewed information about team-based care and hypertension management. So now we're going to look specifically at the pharmacist and the impact of both the pharmacist and team-based care and hypertension management. Next slide, please. A systematic review and meta-analysis was published a few years ago that looked at 121 articles and looked at the effectiveness of different strategies for blood pressure control. They divide these strategies into categories based upon the barrier level that was addressed. Patient level included health coaching and home blood pressure monitoring. Provider level included provider training, audits and feedback, and electronic decision support systems. And multi-level include multi-level strategies without team-based care where physicians titrated medications, and team-based care with titration of medications by non-physician providers. Next slide, please. As you can see from this forest plot, the most effective strategies were the 2 team-based care strategies with medication titration. Team-based care was better than the individual strategies. Next slide, please. We'll shift gears here a little from comparing treatment strategies to look specifically at a treatment strategy involving pharmacists. This study also included Dr. Brettler. In the Los Angeles Barbershop Blood Pressure Study, the focus was Black barbershops where barbers and field interviewers checked blood pressures and referred men to a pharmacist if their blood pressure was elevated. The pharmacist met regularly with barbershop participants, prescribed antihypertensive medications, measured blood pressure, encouraged lifestyle changes, and monitored electrolytes. At each visit, 5 blood pressures were checked. The first 2, were thrown out, and they averaged the remaining 3. And during the study period, blood pressure checks were performed by the barber pharmacist each month. From this study, they found quite a significant difference in blood pressure reduction through the pharmacist's intervention. In fact, a 21 millimeter mercury greater reduction was achieved, and 64% within the intervention group achieved a blood pressure less than 130/80, compared to 12% in the control group. This intervention truly had a profound effect on control and was a unique community-based health intervention, which has been duplicated and used in other settings as well. Next slide, please. In alignment with that study was another study published last year by Kaiser Permanente, who identified that a greater percentage of Black versus white adults had hypertension with uncontrolled blood pressure. They examined the changes in blood pressure control before and after implementation of a quality improvement program, which began in 2010. A key part of the quality improvement program, which we mentioned, was development of a standardized medication treatment protocol or algorithm. Next slide, please. You can see from these graphs here the results of the study. The graphs show the age-adjusted proportion of patients with blood pressure control, with the left graph showing females and the right graph showing males. The orange line designated patients who are Black, and the gray line designates patients who are white. Improvement was seen across all groups, with the greatest improvement with males. Next slide, please. Through the study, the Black-white control gap decreased significantly, down to 3% compared to a national 15% rate, and the overall rates increased as well. While the racial disparity in blood pressure control between Black and white patients still existed, it was markedly decreased. There are a couple of takeaway points from this study. A standardized medication treatment protocol, starting with 2 medications that are in complementary classes, is really foundational to controlling blood pressures across all demographics. A standardized treatment protocol is a must. Also, using team-based care is an important aspect. Furthermore, more focused interventions may be needed in Black patients with hypertension to help address adherence. And my apologies, as a couple words were left off of that last line. Next slide, please. So we talked about what intervention approaches have the most impact on blood pressure control. Of course, team-based care. We discussed a study with pharmacists in Black barbershops and how Kaiser narrowed the disparity gap in blood pressure control. Both of these studies used a standardized treatment protocol. Now we're going to turn our attention to a meta-analysis that came out this year looking at healthcare professionals and who impacts blood pressure the most. They looked at over 100 articles, which encompassed over 90,000 patients total. They divided the data into categories based upon the providers delivering the interventions and came up with 6 categories: pharmacists, nurses, community health workers, multiple providers, not a team-based care approach, but different people involved, educators, and physicians. Next slide, please. Interventions within the study could be health coaching, team-based care with medication titration by a physician, or medication titration by other team members, or multi-level interventions without team-based care. Next slide, please. Here we have another forest plot with the results. The interventions led by pharmacists and community health workers actually came out on top as most effective for systolic blood pressure reduction, and similar changes were seen in diastolic blood pressure as well. This study has quite significant public health implications. In real-world clinic and community settings, there's a serious need for effective interventions that will improve blood pressure control. access to pharmacists, particularly who can make blood pressure medication adjustments, as well as address cost, adherence, and side effect barriers, in addition to access to community health workers who have extensive cultural understanding and are often embedded within the community, could significantly impact blood pressure control and ultimately decrease the incidence of cardiovascular disease. Involving pharmacists and community health workers in team-based care efforts to control hypertension should be a priority. Next slide, please. We know that interventions made by a pharmacist can improve hypertension as outlined in the past study and many others, but how cost-effective is it to have a pharmacist involved in the medication management portion? Last year, an economic analysis was published which based their data on observations from a Canadian study called RX Action, which showed that pharmacist intervention led to a mean 6-month reduction in systolic blood pressure of about 18 millimeters of mercury. Within the study, the pharmacist performed blood pressure assessment and counseled on hypertension. Medications for hypertension were reviewed, medications were prescribed as needed, and follow-up occurred every 4 weeks until blood pressure was controlled for 2 visits in a row, and then follow-up occurred every 12 weeks. For a total of a 24-week study. Next slide, please. Based upon the data from the RX Action study and the amount of blood pressure lowering, this economic analysis suggested, and this is based upon 92.1 million people in the United States with uncontrolled hypertension, and assuming 50% of individuals could access the intervention, that expanding pharmacist involvement in hypertension management could prevent 15 million heart attacks, 8 million strokes, 4 million cases of angina, and 4 million cases of heart failure. A savings of about $10,000 per person over a 30-year time horizon was estimated, with a cumulative population level savings of $1.1 trillion and saving 30.2 million life years over 30 years. These numbers really are staggering, even looking at the events avoided, not even looking at the potential cost savings that they estimated. Next slide, please. After looking at all this data, we come back to where we started with our barriers to hypertension control. While we cannot fix all of these barriers, we certainly have enough tools across the team working together to address many of them. Team-based care truly improves patient care and can change lives. Next slide, please. Team-based care can be different across settings. Each team must determine how to best structure the roles and responsibilities of each member. However, in coming to the end of the talk, I thought it'd be helpful to specifically mention the various roles that a pharmacist could have within that team. Medication access assistance, the pharmacist can identify different formulary options, generic alternatives, less expensive mail order options, and drug company patient assistance programs available. Blood pressure assessment, the pharmacist can use accuracy-validated automated devices to assess blood pressure, and that could be within the office or at the time of prescription refills within a community pharmacy. The pharmacist can provide medication, lifestyle counseling, talking to the patient about their medications, allaying their fears about side effects, and correcting misinformation from family, friends, social media, and also talking to them about practical lifestyle modifications they can make. Identifying and helping to resolve non-adherence. Pharmacists can talk to the patients about their prescription fill history and discuss costs, fears, access issues, which could all be reasons for non-adherence. Medication therapy management. Pharmacists could be involved in titration of medications per protocol, therefore getting blood pressure under control faster. The pharmacist is often in the position of learning about and identifying patient needs, which could be best addressed by pulling in some other team members or resources. I work very closely with our social worker in clinic, as patients may express things to me that I may not be able to personally address, but I know that she has the tools to handle. Advising, educating, pharmacists can certainly help other providers like physicians, APPs, nurses, whether it's in providing answers to drug information questions like drug-drug interactions or in educating providers about new medications. And finally, quality improvement and team planning. Pharmacists can work closely with the team in developing treatment protocols and strategizing about team member roles. And the pharmacist can also play an integral role in assessment of how the team is doing with evaluation of officer system data. While the pharmacist may not perform all of these roles all the time, they probably will assist with many. Some may be affected by regulations within their state and the pharmacist's scope of practice, so those are things that are important to consider when planning. However, pharmacists can make a significant impact in hypertension management and address a number of the barriers to control. Overall, the accessibility of the pharmacist really positions them to make an impact in patient care as part of the team. Next slide, please. Team-based care truly needs to be our approach to hypertension management, and as we have the potential to make huge impacts in reducing cardiovascular disease risk across all of our patient demographics. Teamwork really does make the dream work. Next slide, please. I want to thank you to all of you for your attention today. Thank you.
Thank you so much, Emily. We really appreciate that presentation. So insightful. And I'm sure we've all learned something, and we can take little pieces of that away to help improve our help with our patients and our, the public health that we're looking to help serve. We are now going to open it up for questions and discussions. So if you have any questions for Emily or would like to discuss anything, please feel free to take yourself off of mute and ask away.
Thank you, Emily, and happy week. I'm curious about the barbershop study because I know a little bit about that, but not that specific study. And we do similar outreach here in Wilmington. But I think what you said was they had visits by the pharmacist alone, maybe with a community health worker or somebody else. And then that pharmacist prescribed the medications and followed up, like as a clinic almost? Is that how it worked?
So the pharmacists were working in conjunction with the patient's primary care provider, or if not, with a physician who they were working under. So this was under the supervision, but they did follow a protocol and had specific medications with it outlined.
But just the fact that they were there, like working with whomever, like whatever clinic, just the fact that they were there, say you get your haircut every couple weeks or so, and that they were there and able to follow in that time frame has made it possible, really.
Yes, and certainly Dr. Bretler can chime in about some of the specifics of how it was set up as far as when the pharmacists were in the barbershops.
Yeah, so one of the main sources of effectiveness was the setting. And so, as you mentioned, patrons would visit the barbershop on average every 2 weeks and had significant duration at those sites too, so often 10 years or more. So it was a great setting to create both frequency of touch, which we know is important, and also trust building. So the pharmacists were actually embedded in the barbershops. They would have set schedules where they were physically there in person. They would either check the blood pressures, or in some cases, the barbers themselves were trained as well, and were involved as peer mentors also. But essentially, the patrons would come in every 2 weeks, and they would see the clinical pharmacist, get their blood pressures checked, meds would be adjusted, and so forth. So it was a highly effective model, both from the perspective of the actual setting for trust building, but also the role the specific role of the pharmacist and the medication protocol. So we used a medication protocol which consisted of a long-acting ARB and a CCB, and then a diuretic was added as third agent. So it was a little bit different than the KP protocol, but it was incredibly effective. And even in the KP group, because we had about 25% of the patients in the barbershop trial that were Kaiser patients, those patients were all uncontrolled and achieved control rates. Emily showed the 130/80 data, but the 140/90 data was almost 90%. So very very highly effective model.
Thank you.
If I can chime in, because I'm going to have to leave, so I apologize, but I would like Jeff or Emily. One of the things I think that we're now learning is not only the percent control that you were able to achieve and programs such as Hearts achieves, but the rapidity, how fast that control is obtained. I'm reading some newer literature saying that the time to control also markedly impacts outcomes, not just the percentage on a graph. Has that been your experience, Jeff, Emily, as well?
Emily, you want to jump in first?
I'll let you go ahead,
Okay.
since you are the hypertension
Well,
expert.
no, you are equally, if not more, the expert.
Please.
Yeah, the rapidity is critical, and inertia is really the enemy. We talk about this a lot in our training sessions and workshops. Inertia is the enemy at all levels of the health system. We typically ascribe a lot of inertia to the patient. They don't want to start meds. They want to try lifestyle, etc. But really, it's incumbent upon the health system to look at all the sources of inertia as well too. And I think really it's more actionable and more significant at the level of health system. So we create a 2-week follow-up. ACCHA says at least 1 month, as does WHO, but we like 2 weeks. You should be able to achieve steady state with all of our usual medications by 2 weeks. And it creates a sense of urgency with both the patient and clinician. So telling patients they need to come back in 2 weeks, I think has been a critical element of our program. And definitely you can achieve control rates much quicker. And as Don mentioned, time to control is important and definitely emerging concept. And there's data that you begin to see signals of increasing CVD event rate, once you start to get out more than a few months. So if you can, I mean, that's just the start of the signal. But if you can really bring patients back quicker, I think it just creates a much more efficient cycle.
So Erica, this conversation is really timely and follow up. Erica and her Novant team are participating in Constellations Learning Collaborative as well. And we were talking yesterday during one of our meetings about reaching out, enhancing what they're already doing around health equity, and reaching out using their heat maps to find a hot spot, if you will, in one of their rural areas. And we were talking about that they haven't had as much success as they would like working with the faith-based communities, so that maybe we talked about perhaps they have a mobile unit, maybe going out to a rural food bank, but maybe we need to find a barbershop, Erica, and copy.
We do the barbershops locally within Wilmington, and I don't know
But
that
maybe we
have...
find one out in a rural area.
I know. That's exactly why I was asking about the pharmacist, because I'm not sure that we include a pharmacist. I feel like we just do I'll have to look into that. I feel like we do the blood pressure checks, and there's a community health worker there, perhaps a nurse. I'm not sure about the pharmacist, but I was thinking exactly what you're thinking.
Yeah, I'm saying this is very timely, because we just had a conversation about, taking the mobile unit out into a rural area. Because Erica and her team work with stroke patients, but we want to expand the work from secondary prevention into primary prevention and work more with primary care teams, and she has an amazing pharmacist on her team that
We
works.
do.
Yeah, Rosa couldn't be here today, but she'll likely, and I'll send her a message to tell her happy week too. But just getting her input into this too, and how we might incorporate the pharmacists into the mobile unit. But anyway, good food for thought for our next meeting.
Yeah, I mean, you definitely would catch, actually, I was just talking to Tom about this morning. I was like, well, it's time for your haircut, because he goes every 2 weeks, like on calendar. We know when he's getting his haircut. So you'd catch males, and then maybe at the food banks, you may catch a higher population of female. I don't know.
Yeah,
That you
yeah,
could
do
do both.
both.
Mhm.
Yeah, do both. This is very exciting, very timely, Emily and Dr. Bretler.
I would just add that there's a lot of interest in modifying the model. Pharmacists is an incredibly valuable resource, maybe one of our most valuable resources. So having them go to different sites may not be the most efficient model. So, I think there's a lot of interest in this whole potential model of care to perhaps have a community health worker, a medical assistant, or so forth, be the actual person who interacts with the patient, and then the pharmacist is virtual. Whether that works as effectively or not is not completely understood.
But we could do our own study on that
Absolutely.
and see how it works. And on Erica's team, she has a community paramedic also. She has community paramedic and community health worker that work very collaboratively. In fact, the community paramedic joined our meeting yesterday from her car. She was out making some visits. So this is really exciting. I keep saying that I really wish we need to look for some grant funding to do the in-clinic pharmacist pilot that we're doing in South Carolina and North Carolina too, because Erica's team is ripe for embedding a community pharmacist into.
Oh, we need that so badly. Yeah.
Yeah, and that's something else on our list that we'll keep talking about, Erica, because we got to find some resources to be able to do that, because Erica and I met each other on the COMPASS study. It's been 2 or 3 years ago now, but it spanned 6, 7 years. Comprehensive post-acute stroke services study, and we built networks in our teams across the state and to address risk factors for stroke, including hypertension. But one of the lessons learned from that study was the critical role of a community pharmacist. And the teams that had a community pharmacist particularly embedded, we just saw for all the things that you listed, Emily. We think that pharmacists are, and they are, all about medication management and adherence, but all of the other things, with controlling blood pressure, but also other risk factors. We worked with community pharmacists that in their practices, they had weight management that they did, as part of their practice. And just it was kind of endless what we learned. And that's one of the things that we wrote up in our lessons learned, was the value of having a community pharmacist on the team. So lots of food for thought, Erica and Rebecca.
Thank you so much for those questions and discussion. Does anybody else have any questions before we move on?
Just thank you, Emily, and all of you for the discussion.
Yes,
Yeah,
thank you
thank
to
you.
everyone for the input, and it's wonderful to hear about what you guys are doing in Wilmington and all the different opportunities available and things for us all to be thinking about, exploring.
Thanks.
Well, as a reminder, we are always looking for a case to review. So if you do find that you have an interesting case, it does not have to be a current patient. It can be an interesting case from a previous patient. We would love to hear about it. You can go ahead and put that into the red cap, and we would get that submitted in for one of the applicable eye echoes. Our next echo session is actually going to be, we've changed the cadence just a smidge because of Thanksgiving and Christmas rolling around. So we've gone ahead and combined the November and December into one. So it'll be Thursday, December 12th. Invitations have already gone off. I'm sorry, have already gone out. And that's from 12 to 1. And that'll be utilizing social determinants, the CPT and Z codes. And that will be by Shannon Chambers with SCORE. Please remember to complete your post-echo surveys. You will receive the email at the end of the presentation. Give me about an hour or so to get that out, and I'll send those out. And that will have your link for your survey, and that way you can go ahead and let us know if there's anything that we can work on, and just tell us how we're doing. We'd love to hear that. And that will also get you credit for your continuing education credits. And we would just like to thank you so much for participating in our echo session today. Thank you again, Emily. We truly appreciate your knowledge that you shared with us, and your presentation was incredible. We would love to thank everybody who has participated and wish you a great rest of the day and a great rest of the month. And we will see you in the beginning of December. So have a nice Thanksgiving, because we will not see you before then. So have a great holiday.